and I'm also the director of the MS Center here, which didn't exist 24 years ago. I came here from the East Coast, where I've been on the faculty at Georgetown University. My wife and I decided this is where we should live, and I had no idea what I was going to do. I mean, I had no intention of opening an MS Center, was not even on my radar screen. And I came here and I was approached by someone, asked if I'd start one. So I said, okay, but only if we have 100 patients by the end of the first year, because it's a big undertaking. And we had like 350 patients, so we now have over 4,000. And that's a lot. And we're very proud of what we've done. And we hope we've really served the community. We do many different things. We take care of people. I hope we do it well. We do clinical research. The registries are examples of some of that. But we also do basic research in animals, because we are also involved in research, looking for new agents to treat MS. And I'm not going to talk about our own research, because that's not a good thing to do. But this is a very, very important and exciting adventure. Just as a little bit of background, before 1993, there were no approved medications of any sort for MS. No medication had ever demonstrated sustained efficacy or benefit to patients with MS. And then in short succession, over a period of 7 years, 4 drugs appeared. And that was the beginning. Now we have over 30 drugs of varying efficacy, varying mechanisms, and I'm going to touch on that tonight. I will tell you, though, that I may not mention a medication that one of you may be on. It's not because I don't think it's a good medication or that it's not helping you. It's just I'm going to try to create a narrative, and the medications that I'm going to mention fit into the narrative, and that's why I've selected them. This is the agenda, and it's all related. And I want to start out by talking about sort of what we've learned about why MS happens. Still a lot more to learn, but what we have learned is very significant. And then using what we've learned, how medications have been developed based upon the knowledge of how the disease unfolds. And then I want to talk about the challenges that remain unmet, and they are big. And any person with MS can attest to what still we haven't been able to do for them. So let me start out with finding out if the advancer works. Let's start. Hey, okay. Now, why does MS occur? There are all sorts of theories. I'm an advocate of the inside-out theory. Now, what that says is that the disease actually starts in the brain or spinal cord, and that an event occurs which alters the immune system that leads ultimately to the evolution of MS. Now, the inside-out theory would say that some injury to the central nervous system, and most of us would opt for it being injury to the, and I want to say brain, I mean spinal cord too, an injury to the brain by infection, presumably a virus. And over the years, there have been lots of candidates for this. Measles virus for many years was thought to be what caused MS. And the reason for that was in the era before we had vaccination of children for measles. Every winter, millions of children around the world got measles, and some of those children got encephalitis. Some of them died from it. And if you looked under a microscope, it looked superficially like MS. It was discovered that measles can reside in the brain to produce a disease that we don't talk about much anymore called subacute sclerosing panencephalitis. It's all wrong. Measles has nothing to do with the disease. And a lot of people worked very, very hard on the presumption that it was. And for leading candidate now, there's something called Epstein-Barr virus or EB virus. And it's the virus that causes mononucleosis. And I'm going to be talking more about that as we go on. But let's say in this model, the brain is attacked by a virus. It damages tissue. Now, it turns out that the brain has within it its own immune system, an innate immune system made up primarily of 2 cells in the brain. And it will try to clean up the mess, kill the virus, let's say, and stop the damage from going on. But also these cells send out chemical signals that leave the brain and get out into the periphery to bring in the systemic immune system that we employ to fight systemic infections. So it becomes like a 2-pronged attack. Then what happens is the cells that are in the brain, macrophages is the name of one, and something called lymphocytes, they'll actually ingest the debris that was produced by the damage. That ingestion of the debris actually helps turn off the excitation that's caused by the disease. And then what happens is these white blood cells that have entered to attack, to kill the virus and clean up the shop, they leave and they go out into circulation, or they go into something called lymph nodes. You've all heard of lymph nodes, right? And they go to lymph nodes where they program the cells that are in the lymph nodes to know about this infection by presenting chunks of what they ingested. And in that way, program the lymphocytes also to be sensitized to this thing that attacked. So it's inflammation, so we make a flame. All right, so let me just point a little. So the idea that would happen here is that there's acute inflammation in the brain. And then these white blood cells, having carried out fragments of myelin, fragments of nerve fibers that they've ingested, will digest it, process it, and then present a signal on the surface. This white blood cell, let's say it's a macrophage, enters the lymph node where there are these cells called lymphocytes. It presents it to these lymphocytes and thus educates them, programs, gives them a memory. We call these memory lymphocytes. All right. Now, here's a B cell, it's a type of lymphocyte, and it met a macrophage that gave it that little piece of digested material from the brain. It ingests it, it degrades further, and then it presents it to a T cell lymphocyte, which is the attack dog for the future. And this B cell T cell combination is called our adaptive immune system. Now, every living organism, including a fungus, has an immune system to protect it. But it's only vertebrates that have developed this adaptive immune system. It's like a computer you can program, giving vertebrates the ability to adapt to threats. It's the basis of vaccination. You can't vaccinate a cabbage, but you can vaccinate a sparrow because it has an adaptive immune system that can take the material from the vaccination, develop a memory, and if the bad guy shows up, it's ready to go. That's how vaccines work. They depend upon this other immune system called the adaptive immune system. And how have we adapted it? We adapted these two types of lymphocytes to now be ready to recognize any more of that stuff that was broken down and transported out of the brain and spinal cord. Everybody got that? Good. And as I pointed out, these memory cells that have been made in the lymph nodes are constantly leaving the lymph nodes, and they're in circulation. So it's like scouts looking for a problem. And if they happen to come to an area of the brain or spinal cord where there's inflammation, signals sent out by that inflamed tissue attract these cells to enter there. And in there, if they encounter what they've been programmed to, like a piece of broken down myelin, that activates them and turns them into attack cells. So here we have a blood vessel. And let's say that this is one of those circulating memory lymphocytes. There's inflammation going on, and it's sending out chemicals to attract this white blood cell to that blood vessel wall. It migrates through the blood vessel wall, gets into the brain, and if it encounters in the brain what it has been programmed to recognize, it becomes activated. And when it becomes activated, it attacks. So this is supposed to be myelin on a nerve. So what happens is these immune cells directly attack to destroy myelin, because after all, it's been told it's the enemy, right? But also it recruits other cells to do the same thing. And these cells, along with the original cell that came in, secrete pro-inflammatory chemicals called cytokines. And they also add to the damage. What does this look like under the microscope? So this is an autopsy specimen of a patient with MS. Now what we see here is a blood vessel filled with a clot. See all these black dots? Those are all lymphocytes that are migrating. Here's the wall of the blood vessel. You can actually see them in the wall of the blood vessel. They migrate out of the blood vessel into the brain where they will do damage. And this is what the damage looks like. So this is a special kind of stain using antibodies that fluoresce. And you can identify different substances. And this would be like in that lesion I just showed you, okay? So red is myelin. Yellow is a nerve fiber. And you see here that some of this disappears down to blue. I hope you can see that. That's because there's been a denuding of the nerve fiber. There's no more myelin. You can actually see myelin being peeled off right here. See that? And you can see the axon changing color to a blue color. That's demyelination. But there's something else that happens that's extremely important. Can you see this blue blob? Can everybody see that? Mm-hmm. All right. That is a nerve that's been cut in half by the inflammatory process. This was the nerve fiber right here. And it got cut in half, and this nerve has sort of squeezed out its contents like out of a toothpaste tube. That nerve is gone forever. It's lost. This is common. It's been estimated that in 1 cubic millimeter of active inflammation, like I'm showing you, over 1,000 fibers are permanently destroyed. And you multiply that by the volume of lesions, the number of lesions, and the new recurrent lesions, and it's no wonder after time, if this isn't dealt with, that there's growing damage and disability. Let me show you some more about this. This is a special stain. It's called confocal microscopy. And this, every one of these that look like a balloon on a string, it's a cut axon, permanently lost. So the first principle, right off the bat, is that if there is a relapse, we want to stop that relapse as quickly as possible, because we want to limit the amount of damage, permanent damage that's done. And we generally do that with high dose intravenous steroids. And I have no doubt that some people in this room, for instance, at some time have received intravenous solubentrol, for instance. And the purpose of that is to shut down the relapse. Everybody okay so far? Okay. Now, so if we look on an MRI scan, that slide I showed you, this is what it looks like on an MRI scan. So this is a patient who's been given gadolinium. And the reason that we give gadolinium is if gadolinium enters the brain, we know there's an active lesion, not an old lesion. It's an active lesion, and there are two of them. There's a little tiny one here, and then there's this bigger one there. Gadolinium is not supposed to get into the brain. It's supposed to stay in the blood vessels like there, and there, and there. But when there's a breakdown of the barrier, just as normal as white blood cells flood in, so do proteins from the blood, and gadolinium is attached to the blood protein. So the presence of a gadolinium-enhancing lesion tells us, even if there are no symptoms, if there's active disease going on, that we would want to stop. There is no such thing as a benign relapse. I've heard people, doctors say, well, you know, they have to focus a little on relapse, but that's all right. It's not all right. Because every time a relapse occurs, nerve fibers are permanently destroyed. And over the long years of the person suffering from MS, the accumulation of that takes a toll. So we want to stop every relapse as quickly as we can. All right, now, depending on the size of one of those gadolinium-enhancing lesions and their location, a person may actually get a clinical relapse, whether it's a change in sensation, a change in strength, a change in vision, a change in balance, worsening bladder control, whatever it is. Not every relapse, not every MRI lesion like that produces symptoms. It may be small, or it may be in a location where you don't produce obvious symptoms. It's been estimated that only 1 out of every 10 new lesions in MS actually produce symptoms that are recognizable. Therefore, the need to do MRI scans, even when people are not symptomatically different, is of paramount importance, because it may show us that we're not controlling disease when we thought we were. All right? We found in a study we published a number of years ago that 1 in 6 patients, 16% of patients, had new MRI lesions on a year-by-year basis. And these are people on therapy, year-by-year basis, that produce no symptoms at all. So that's why we keep on doing MRI scans every year, is to prevent not seeing this. Now, symptoms of relapse may completely go away, even if you're not treated. But more commonly, actually, they leave a residual deficit. and they leave a neurological residual disability that accumulates over time, and this is progression of disability related to relapse activities. Now, I want you to pay attention to the two gold lines on the top of this graph. These are the descriptions of the patterns of the most common form of MS, relapsing and remitting MS. So here we have a baseline, and the person gets worse. That's the relapse. They stabilize and they get better. That's the remission. And the way this was understood was that people recovered, and maintained their baseline. That's not what happens for most people. What happens instead is a person has a relapse and does not completely recover and is residual deficit. They have another relapse and now the residual deficit's higher. And through this means people accumulate deficit over time due to relapses. Lesson number 2, we want to prevent relapses because relapses are associated. We want to stop them if we can completely because relapses are associated with increasing sustained disability over time. And it's this data that makes it of paramount importance to understand that. We're going to get back to the light blue and the pink and the orange line a little later, because you're going to see the slide again in a slightly different context. Okay, now, how's MS treated? Well, we can do a couple things. We want to intercede somewhere where we can block the chain of events that lead to MS disease activity. Now, it's because basic scientists and preclinical scientists have really slayed over these last 30 years to elucidate and teach us so much about why MS is happening, what is driving it, that we now know that there are a series of steps that we can reliably understand. That in turn can serve as a guide as to what you want this medicine you're going to create to do. And it's been that knowledge, long before I'm in the dark, but being informed by the results of careful basic research that has led to ever more specific and ever more efficacious drugs because they are honed in on what we know about the mechanism of the disease. Okay, so what can we do with strategies? Well, one thing we might do is we might prevent lymphocytes from being programmed to become memory cells. Or alternatively, we know memory cells reside in lymphocytes. Can we prevent them from leaving the lymphocytes and getting into circulation? Or if white blood cells, memory cells are already in circulation, can we prevent them just from entering the brain and spinal cord? Or can we destroy circulating memory cells that would damage the brain and spinal cord by destroying them in circulation? Or can we simply change the behavior of memory cells in circulation so they're not activated? And each one of these strategies get a good clinical result. And the answer is yes, 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 yes. We have medications that work in all of these different scenarios that have a beneficial effect in reducing relapses, reducing brain damage on MRI scan, and in many cases, reducing the acquisition of increasing disability over time. How does this happen? Now, you may remember, let me go, I wonder if I can go back. This will let me go back. Remember this? All right. Remember how this takes place? Well, we can prevent that from happening. Let me show you how. In order, let's say for a presenting cell, and we'll call, for the sake of this, we'll call this either a macrophage or a B cell. This is the chemical that's going to program and give memory to a T cell lymphocyte. And it's sitting right there, ready to be presented to this cell. But in order for this to be aligned and be precise, you need something to stabilize this. And this is called a co-stimulatory molecule. Imagine trying to take a 3-pronged plug and stick it into a 2-slit outlet. Won't work. Or if the prongs are horizontal instead of vertical, but the outlet is vertical, it won't go in. So you have to get alignment. And that's what the co-stimulatory molecules here do. Now I want you to pay attention to this right here. This is part of the T cell. It's called CD40 ligand. And this is the receptor to which it attaches, CD40. We now have a drug that can disrupt this to prevent this lining up. It's still investigational. It's called, I can never pronounce it properly, frexalimab. I did it. All right, it's a new agent. It's an antibody that sticks its nose, sticks itself right in here and prevents these from aligning. And theoretically should prevent the creation of a memory cell. It's an investigational agent. It's currently in clinical trials that are just beginning. But this could be very important by stopping the disease in its tracks very early. Now, another approach is to change the behavior of the lymphocytes so that they simply can't mature. They can't activate. They can't carry out their deed. And a medication called teriflunomide or robachia is an example of a medication that does that. Now, in order for these cells to function, there are nucleoproteins, that's what RNA and DNA are made out of. They're needed to regulate, control, and activate these cells. But if you deprive these cells' ability to make those molecules, you can deactivate them and make them incapable of carrying out their action as activated cells. And that's what teriflunomide does. It interferes with an enzyme in the part of the cell that makes the energy necessary to do the synthesis of these nucleic acids. Very interesting. So here's something called a mitochondrion. For those of you who took biology 101, you remember what that was, sort of. And in every living cell, mitochondria actually make the energy the cell needs to survive and carry out its functions. And what teriflunomide or robachia does is it blocks one of the key enzymes that are necessary in the creation of the energy, so this cell can't act as an activated cell because it doesn't have the molecules necessary to make it have that kind of behavior. So now we've got two strategies. We can prevent the cell from being turned into a memory cell, or we can take a cell that is a memory cell and interfere with its metabolism in a way that prevents it being activated. It doesn't destroy the cells. It just makes them underfunctional or non-functional. All right. Another thing we could do is maybe we can block the memory cells from getting out of the lymph nodes. Okay, they've been programmed, but maybe if they don't get out of the lymph nodes, they can't get into the brain and spinal cord. And indeed, we have medicines that do that. They prevent memory lymphocytes from leaving the lymph nodes. Sometimes you get a really lucky break. So really the type of lymphocyte that drive the show in inflammation are memory lymphocytes. So these drugs came along, and lo and behold, they block lymphocytes from leaving lymph nodes. Wow, that's terrific. After the drugs worked, after they were approved by the FDA, it was discovered that they selectively block memory cells from leaving, which are the driver cells. Serendipity at its best. All right. So these medications, fingolimod or Gilenya, siponimod or Mayzent, ozanimod or Zeposia, or ponesimod, known as Ponvory, all of these act by preventing memory lymphocytes from getting out of, called central memory lymphocytes, getting out of lymph nodes in the spleen. And what do? They definitely prevent relapses. They definitely reduce damage and new lesions on MRI scan. And in most cases, they definitely reduce the risk of further disability increases over time. Now, I made this slide, that's why it's so funny. Okay, so this is a lymph node a la Cohan, and that's the lymph node here. And there's a constant circulation of lymphocytes coming in and leaving. But a very interesting thing happens. The central memory lymphocytes are held in place, imprisoned by a chemical called CCR7. It's actually a receptor, and it keeps the cells there. How do the cells get out? Well, there's another chemical in our body called S1P. Travels in our blood at very high concentrations. SIP also enters the lymph node, and when it does, it interacts with this receptor on the surface of the cell, which liberates it from the bondage of CCR7 and allows it to exit the lymph node and go into circulation, to act as a surveillance cell, looking for inflammation, looking for a place to attack. However, if we use one of the four medications I just told you about, and here it's like an inverted pear or light bulb, it attaches to the pore of this receptor, so the S1P can't get here So therefore, the cell remains entrapped by CCR7, and you do not see central memory cells within. So you've reduced the number of cells that have the ability to attack the nervous system by not letting them out of their storage sites. You no longer have the immune surveillance of these cells. Reduces relapses, reduces disability progression, dramatic effect on MRI scans. Now, you can also just, deep and dirty, just destroy the cells. And it works, believe me. So there are 4 medications we currently have that are used in MS. Ocrelizumab, rituximab, ofatumumab, and just to try to make something I couldn't pronounce, ublituximab. All right. By the way, the MAB means monoclonal. The first half, I got no idea where they got that from. All right, now, B cells. Remember B cells, how they can introduce the activate T cells? Well, immature B cells, mature B cells, and the memory cells, which are the real villains here, all express a chemical on their surface called CD20. The progenitor cells, the immature cells don't. And the cells that they eventually become, which make antibodies, also don't have it. Now, any one of these 4 medications, in this case, ocrelizumab or Ocrevus, if these cells are exposed, it attaches to CD20 and destroys the cells. And in unbelievably rapid time, these cells just disappear from circulation. Dramatic reduction in relapses, dramatic reduction in new and enlarging disease on MRI scans, and very significant reduction in the accumulation of disability due to relapses. Now, this is a little repetitious. I think I've already said this. Okay, now let's go back to this. The reason I'm bringing the slide back up is to remind you what a key step destroying a B cell is, because this entire cascade of events that leads to the adaptive immune attack depends upon, in large measure, B cell presentation of antigen. You've just done away with this. Again, using the knowledge of the steps of how MS occurs to create medications to intercede, thus the anti-CD20s. You can also interfere and destroy B cells by interfering with their metabolism, not just crippling them, but destroy them. And cladribine, or Mavenclad, is a medication that does just that. It gets into the cycle of the DNA making and makes new DNA impossible, and therefore kills the cell. So Mavenclad also reduces relapses, reduces changes on MRI scan, and probably decreases progression of disabilities due to relapses. Another example, destroy the cells, you'll get a good clinical response, and these are all relapsing patients. All right, now alemtuzumab, also known as Lemtrada, is an anti-CD52 antibody. CD52 is expressed on the surface of cells. Alemtuzumab attaches to it and kills them, but it's a much more broadly based cell killer. It'll kill B cells, it'll kill T cells, it'll kill monocytes that make macrophages, and also something that we're not going to talk about anymore tonight called dendritic cells, which are antigen-presented cells. So it has a broad range of cellular destruction. All right, and it definitely reduces relapses, MRI disease activity, and worsening over time due to relapses. And this just shows you as an example of what it does. So this is a slide of over 2 years of treatment. You only use this drug twice. So the first treatment in year number 1, T cells and B cells plummet. Then over a period of 12 months, gradually recover. You hit them again, they gradually recover. This medication works for years, right? Because the immune system is so slow to reconstitute itself. So there's another strategy. Let's destroy the cells. Now, the problem with all the medications I've just shown is, sure, they destroy or modify or inhibit cells from getting out into the circulation and into the brain and spinal cord. And they're all very effective. But the problem is they're also interrupting the immune system in places other than the central nervous system, like the lungs and the bladder, and et cetera, et cetera. So you worry about these medicines that not only have an effect in protecting the brain and spinal cord, but have a systemic effect in suppressing the immune system. Will that make people susceptible to certain diseases, such as serious infections, and even in some cases, perhaps some cancers? That's a worry. So a different strategy would be to say, yeah, we're not going to destroy the immune system. We're not going to inhibit the immune system. We're just going to not let it get into the brain and spinal cord. Thus, natalizumab or tisabri. So rather than destroy immune cells, instead, can we prevent white blood cells from attaching to the surface of the blood vessels in the brain and thus can't get into the brain to push the disease, new relapses, more destruction? And the answer to that is yes. And let me show you the next slide. So you've already seen this slide of our attack dog, our lymphocyte, getting to an area of inflammation, being attracted to the blood vessel wall. By the way, the inflammation going on here leads to the production of chemicals that attract, like a dog to a bone, these cells to come here. They attach to the blood vessel wall, they migrate in. Once in, if they encounter what they are programmed to recognize, they become activated and attacked. This is something I've shown you already. How does that happen? Well, a memory cell in circulation will express a docking molecule on its surface called alpha-4 integrin. This molecule is specific only for the blood vessels of the nervous system. It does not work on any other organs except the colon, of all places. No one knew that there was an ass-brain connection, but there is. And alpha-4 integrin basically is only interactive with blood vessel walls of the central nervous system. So here's alpha-4 integrin being expressed on the surface of a lymphocyte that is a memory cell. It encounters a receptor called vascular cell adhesion molecule, which is expressed by the cells lining the blood vessel wall overlying areas of inflammation, thus the dog and its bone. The alpha-4 integrin attaches to the VCAM. This activates this lymphocyte to make enzymes that break down the barrier of the blood vessel and allow the white blood cell to migrate into the nervous system. What does natalizumab or tisabri do? Well, it's an antibody that's specific for alpha-4 integrin, so it attaches. Now what happens is there's no way that this lymphocyte can interact with VCAM, and it just goes on its merry way until it dies. No damage done. The natalizumab will recirculate, attach itself to more cells. And you see a clinical effect of natalizumab up to 6 months after even single dose, which it keeps recirculating and being reused as the cells that attach to die. So here we have an example of a medication which very effectively reduces relapses, basically totally eliminates gadolinium-enhancing lesions, reduces other lesions in the brain, reduces disease progression to the relapse. So you can see we have a rather rich array of medications which are highly effective, each created out of the understanding that was created of how these steps take place. The early medications, the interferons, glatiramer, which is Copaxone, guess where? You know how Copaxone was developed? A group of Israeli immunologists wanted to make a chemical that would produce worse EAE or MS in mice instead of prevent it. That's how that was discovered. Interferons were approached because interferons got a lot of play as antiviral agents, and it was thought that MS must be a viral disease, so let's use interferon. Very little was known about the interferons. And a guy named Larry Jacobs basically went down to the pharmacy at the University of Buffalo and said, give me an interferon. And they said, which one would you like? He said, what do you have the most of? Well, beta interferon. That's how Apodex was created. All right. If you use gamma interferon, which is pro-inflammatory, but was not known at that time, people would shy away from interferons, and tens of thousands of patients around the world wouldn't have had those medicines to benefit them. But those days are over, the lucky guessing. From here on in and up till now, in the last especially 15 years, medications are being developed, growing out of our knowledge of how the process takes place. And that's why these medications are so much more effective and so much more specific. But the problem is that this solely deals with relapse. And we have another challenge. All the currently approved medications all reduce the risks of MRIs. They all reduce the risk of MRI scans. But really, they don't significantly reduce the risk of progressive disease, which occurs in the absence of relapses. You get a medication which is extraordinarily effective, completely shuts down circulating pro-inflammatory cells. And for some reason, even though the patient's not having relapses, many patients continue to worsen. Let's go back to the slide which I showed you before. Well, now I want you to look at the light blue lines. So patients who have had relapsing remitting disease go on to what's called secondary progressive disease. But they still might be having some relapses, but they're getting worse between the relapses. Here. And eventually a point is reached where there are no more relapses and they continue to worsen. That's secondary progressive. And primary progressive, patients never had relapses in the first place. They just were progressively worse in the very beginning. None of the medications we have approved really have significant impact on this process. Now, that's bad because when people develop progressive disease, that's when the real significant disability kicks in. That's when the canes and the walkers and the wheelchairs rear their ugly heads. And we've not understood what drove. We were just mystified by what was driving progressive disease. We're not so mystified anymore. I'm going to show you some stuff from. And therefore, we haven't been empowered to try to develop therapies based upon the understanding of why it's happening. All right. Now, this is a paper that was published in 1999. And the question was, from the time a person has their first relapse, how long will it take them to go on to get progressive disease? And this was done in Western Ontario. And the Canadians lagged getting the agents by a couple of years compared to us. So in 1999, there were virtually no Canadians on any disease-modifying agents. And I want you to notice that within only 5 years of onset, more than 10% of people were now having progressive disease. 15 years out, it was 65%, 26 years, 89% of people were progressive. We might say, well, gee, 89, yeah, that's not so bad, 29 years. Yeah, you got the disease when you were 19 and 48 when you were in a wheelchair. What's so good about that? Now, the good news is that with the advent of our contemporary anti-relapse medicines, we have reduced the frequency of disease at this time. And it's been done up to 15 years. We just haven't had the medicine long enough to get these numbers here. But a recent paper that came out of UC San Francisco's MS Center showed that within the first 10 years at least, the frequency of this is cut in half. So we're clearly, by controlling relapses and preventing the pro-inflammatory signals that are coming from the adaptive immune system, are delaying this and reducing the frequency at any point in time, but we're not eliminating it. Now, if we could detect the onset, and let's say we had agents that worked, if we could detect the onset of progressive disease at its very earliest initiation, we might be more effective in preventing it or reducing it. This is not easy. So I'll tell you about a study that was done at Mount Sinai in New York. Excellent, world-class MS Center. They were able to demonstrate that on average, it took them 3 years from the time of the onset of progressive symptoms to make a diagnosis of progressive disease. So all these patients with secondary progressive disease, they went back into their charts to see how long ago symptoms first evolved. They were so subtle, they just simply, the patient was complaining of something, the exam was the same, the MRI was the same. Tough time. But if we could pick it up earlier, we might be able to do a better job. Also, we need to be able to prevent progression that's occurring in the absence of relapses. And we also have to repair nerves and repair myelin in people who've had MS. And lastly, the real apple to pick from the tree is preventing MS from occurring in the first place. Let's look at this a little bit. So here's 2 MRI scans, 13 months apart. This is called a T2 flare. And radiologists looked at these 2 scans and said, you know what? There's been no change. Now you'll notice this fluffy stuff here that wasn't there. Actually, it is here, just at this slightly different level cut. So it all looks the same. Yeah, sure, it's a little darker here, but the lesions are all the same size.
So we see no evidence of worsening on MRI scan at all. Using modern machine learning, AI-based analysis. See the green? That's old lesions. See the gold? That's all new that's occurred in 1 year. Now, this MRI scan has 150 slices in it. And of the 150 slices in it, 25 of them had this going on. So not only can we detect it, but again, using artificial intelligence and pixel analysis, we can actually determine the total volume of the increase in lesions. So here's 2022, the thin line, and the thick line is 2023. That's the total amount of increase in lesion volume, which turns out to be 1.56 mLs, which is a more than, it's about 7.5% increase in the period of 13 months. Knowing that, even though the patients had no change clinically, has had no change on exam, and very talented, very careful neuroradiologists can't reliably see there's a difference, gives us the opportunity to discover this is going on sooner. Now, why is that important? Well, let's talk about probably why progressive disease occurs. Now, I mentioned to you earlier that the brain and spinal cord have their own immune system in place. It's an innate immune system within the central nervous system. And there are two major cells that really form it. One's called an astrocytes, and the other's called microglia. And that's what we're going to concentrate on. The microglia don't start in the nervous system. In the embryo, in the yolk sac, very early on in fetal development, they migrate out of the yolk sac, go into the primitive central nervous system, and then spend the rest of their life there and never leave. And they become sort of part of the brain and spinal cord. These cells have many functions, some of which are protective, some of which promote growth of cells, and so on. But they're also immune competent. And these cells, it is emerging, may be extremely important. Now, understanding of why progression occurs and the development of therapy to stop progression from occurring. One of the things we've seen with microglia, and I'm going to show you examples of it, they may progressively destroy neurofibers, gobble up myelin and neurofiber debris, and also iron. The largest store of iron in the central nervous system is in myelin. So as the myelin is broken down, it releases the iron, and the microglia can pick it up. Now, the fact that they pick up iron is a tremendous advantage to us. So I want you to first look at this. Oh, I didn't mean to do that. I want you to look at this MRI over here. This is a standard T2 flare. See this lesion? That's an MS lesion. All right. But if you do a special series in MS called susceptibility weighting imaging, what you can see is this. Oh yeah, yeah. See this black circle? That's iron. And if this patient died and did an autopsy, you'd see the iron in the microglia at the edge of this lesion. And furthermore, if the patient survived and you did, let's say, MRI scans every 6 months, you'd be seeing this get larger and larger and larger. The presence of these slowly expanding lesions, even ones that don't contain iron, have been closely correlated with the degree of disability. The more of these you have, the larger their total volume, the more likelihood you are to have severe disability. And furthermore, there's a clear correlation between the presence and number of these and progressive disease in the absence of relapses. Furthermore, using PET scanning, everybody still know what that is? Radioactive isotope. There's a radioactive isotope that selectively attaches to activated microglia. If you did a PET scan of this patient, the uptake of the isotope could be superimposed right on top of it. So we know these microglia are activated and they contain breakdown products of nervous system and they expand over time. There's a growing belief that this lies at the seat of progression. And this all comes out of research over the last 5 or 6 years. At the United States, they have patients they've taken care of for 35 years. They went back and looked at the MRI scans from 35 years ago, started looking for these and finding them and following them over time. And now it's unfolding. Now, if microglia are responsible, or largely responsible, for progression, then what do we need the medications to do? Well, we want to stop microglia, don't we? But they have to get into the brain and spinal cord. We've seen that drugs that completely clear the immune system in the periphery don't stop this. So something's got to work in the brain and spinal cord. Almost all of the approved, even the most potent of the medications we have, do not enter the central nervous system. So we need something that enters the central nervous system. And then secondly, they have to have the ability to block or at least inactivate or reduce the activation of microglia. All right. So there's a enzyme called Bruton tyrosine kinase, described by Professor Bruton in the 1930s when he discovered a genetic disease in which this tyrosine kinase was lacking, and these were children who were very susceptible to infection. So BTK, turns out, is found in B cell lymphocytes, and it's found in microglia. It's also found in macrophages. All right. And when BTK is stimulated, it activates these cells. So those active microglia that we see containing iron may be driven by stimulation of this enzyme. Now, there are inhibitors of BTK. They're small molecules, and they get into the brain and spinal cord. They prevent B cell activation. Therefore, they may reduce relapses. But in our current environment, therapeutic environment, more importantly, they also can inhibit microglia. And if they do, could these agents reduce progressive disease, even in the absence of relapses? And this is just a diagram describing what I just said. This is the periphery. This is in the nervous system. There's a B cell that expresses BTK. And if it gets in here, it gets activated, it can attack, but also release pro-inflammatory chemicals, cytokines. Macrophage is the same thing. And in the brain itself is our friend, the microglia, which contains BTK. So if we can deliver enough BTK in high enough concentration that lasts long enough, we might be able to shut down the system that seems to play a major, if not the major role in progressive disease in the absence of relapses. All right. There are currently 3 ongoing trials of Bruton tyrosine kinase inhibitors. There's a 4th drug which failed, a drug called evobrutinib. And it's in retrospect felt that the problems with that drug were, number one, it didn't get into the brain in sufficient concentration. Number 2, it may not have attached to the BTK firmly enough or long enough. And the biochemical characteristics of these 3 molecules are they are much more tightly bound to BTK and stay attached to BTK longer and probably get into the brain in much higher concentrations. 2 of these, fenebrutinib and tolebrutinib, are not only being tested in patients with relapsing disease, they're being examined in patients with both secondary and primary progressive MS. We hope that one of them, the one that's doing all 3, which is tolebrutinib, they will be presenting their final data at the European MS meetings in September. And everybody's on the edge of their seat, because if this comes on, we're too bold. All right. Remibrutinib is just being looked at in patients with relapsing disease. Okay. Now, there's a glimmer of hope that we might be able to stop progressive disease. And I will tell you, there are other agents, not just this group of BTK inhibitors. There are other molecules that stimulate and regulate microglia. There's one called TREM2, and one of the companies is developing an inhibitor of TREM2. And there's some other methods as well. It turns out that a chemical that you find in omega-3 oil that you find in I can't disobey the chance to call a breakdown product of DHA, which is the major element in those omega-3 oils, is anti-inflammatory. It can enter the brain, and it might be able to regulate microglia. So there's at least 3 pathways currently being followed to try to regulate and control to control microglia. Now we're hoping that Bruton tyrosine kinase doesn't, and that's the big next step. And then these other agents can be looked at as well. But the point is we have fallback positions if this doesn't work. Okay. How about repairing myelin, repairing nerves in people who already have the disease? Well, therapeutic trials have been attempted at remyelination, and they've been attempted to stimulate nerve fiber growth, and they have failed. Now, but there's a number of reasons they may have failed. One may be that in each case they were using a big antibody, and antibodies are big molecules. They don't get into the nervous system. It may be that it wasn't enough delivery. Because those very same medicines in tissue cultures and organ cultures, they work. They didn't work in the whole animal. The other thing is that these studies may have been too short. So everybody does studies based upon relapsing studies, which are never more than 2 years. So let's have a theoretical. A person has a nerve fiber from a nerve that arises in the brain. It travels all the way down the spinal cord to supply muscles in the foot. And the person's 6'7". It's a big nerve. It's a little nerve. Under ideal circumstances, and MS is anything but an ideal circumstance, nerves grow, regenerate at 1 millimeter per day. Think how long it would take for that nerve to regenerate, and they stop the study after 1 year. Yeah. All right, so that may be part of the problem. But there are other approaches we can take. For one thing, we know that what turns nerves on to grow and turns nerves off and turns myelination off is all under genetic control. You can't keep on making nerves bigger and bigger and more myelin. You know, there's a time that maturation has occurred, that's as big as it's going to get. How do you turn it off? Well, there are genes that turn it off. And you can block genes. There's something called antisense nucleotides, where you can prevent the gene from expressing itself and fibrillate and disinhibit remyelination and nerve fiber growth. That's one thing. Also, every gene has both stimulator and inhibitor sites. Again, many of them are already known. It's a matter of developing small enough molecules that get into the nervous system to activate or deactivate the appropriate genes. This can be done. This can be done. Gene editing can be done. We can change the milieu and promote genetic driving of repair. It's going to take a long time to do very, very complex work, but it's a way to answer that question. Can we prevent MS from occurring, in the first place? That's the holy grail. And the answer is yes, we probably can. So a number of factors that we all know contribute to a person's risk of getting MS. First of all, there's their genetic profile. Over 220 genes have been identified that contribute to the risk of getting MS. Now, MS is not an inherited disease. It's not like, juvenile diabetes or Huntington's chorea. No. But what you can inherit is risk. The risk of getting MS if some other things happen. So the further you live away from the equator, the greater your risk of getting MS. Probably due to lower vitamin D levels in people who are exposed to less sunlight per year. Very, very important. Childhood obesity is clearly a factor in increasing the risk of developing MS, as is cigarette smoke. Those are possibly controllable factors. But the point I'm making is it's multifactorial. However, what's the trigger? Because most people who live in Finland don't get MS, whether they have good vitamin D levels or not. What's going on? What are the triggers? Well, EB virus may be one of those triggers. Why would we think of EB virus as being a trigger? Well, for one thing, it causes mononucleosis. And mononucleosis is much more common when people have MS than people with drugs. Secondly, if you look in the spinal fluid of people with MS, there are these abnormal immune proteins called oligoclonal bands. Studies show that those oligoclonal bands cross-react with the DNA of EB virus. If EB virus wasn't in the nervous system, why would there be antibodies in the nervous system against them? EB virus lives in B-cell lymphocytes, and people have identified aggregates of B-cell lymphocytes sitting on top of an MS lesion. And in those lymphocytes, you can find, you guessed it, EB virus DNA. Furthermore, a brilliant epidemiologic study done with the US Army demonstrated that patients who were EB virus negative followed year after year. If they became positive, that accounted for all the new cases of MS. Now, EB virus might be the enemy. It might be what starts this mess. So what can we do? Well, we could try to kill the virus. Turns out that EB virus is a herpes virus, like the virus that causes shingles and herpetiform lesions around so on. And you can take EB virus and put it in a test tube, put it in a tissue culture, and use these medicines like acyclovir, and it'll kill the virus, no question about it. It's never worked in a human. We do not see a drop in the viral levels. Maybe because the virus lives inside of these cells. So although people will keep on looking for an antiviral agent to kill it, there's another approach. The approach might be to vaccinate people before they get exposed to the virus. So when the virus shows up, I'm vaccinated, it ain't gonna happen. And there's now very, very heavy effort going into developing such vaccines. Now, the company that brought you, one of the companies that brought you the COVID vaccine, Moderna, is starting a study with their anti-EB virus vaccination. But they're doing it in people who already have the disease. Man, I hope it works. But you don't take a flu shot while you got the flu. You take it before you get the flu. So to me, the better idea is to do it in children. Children who are EB virus negative. You're not born positive for this virus. It happens first 10 to 12 years of life. The problem is that, let's say in North America, about somewhere between 1 and 5 people per 1,000 get MS. You have to theoretically vaccinate 1,000 children for the case. And are these vaccines going to be safe? All that. So I went to a conference a year and a half ago called Actions. And one of the big sessions was vaccines. And they had leading vaccinologists from all over the world arguing with each other in front of us about what they should do. So there are many hurdles, but the thing to do. And it's certainly not outside the realm of plausibility. But you can develop vaccines to prevent the triggers, if there are infections, from infecting the person and causing this disease in the first place. Now, let's summarize. Over the past 30 years, we've gone from having nothing to a rich array of medications that work with varying mechanisms and increasingly based upon our growing knowledge of the pathways that cause MS in the first place. Now, we can control and in some cases completely eliminate relapses and accumulating disability due to relapses. However, we're not able to halt totally the progression in the absence of relapses. We're not able to really repair nerves or repair myelin. We don't yet have a strategy for preventing it that we know works. That's what I've covered. I haven't covered everything. There are enormous topics, like the problems of cognition that 50% of people with MS have. We don't even know why that happens. We have patients who are clinically like as stable as a rock, and yet they can't remember. They can't multitask, get easy distractibility. Why do people get fatigue in MS? 90% of people have fatigue. We don't know why. We have to find out why. And if we can find out how it happens, once again, we can develop medications that answer the mechanism by which this occurs. Depression, anxiety, part and parcel of this disease. The incidence of depression is enormous in patients with MS. And it's not, gee, I'm so sad because I have MS. It is the MS doing that, affecting the portion of the brain that regulates mood and feeling. So we have enormous challenges ahead of us. I don't want to overemphasize our accomplishments at the expense of understanding that we have a great deal of work to do. What is encouraging is that this work is going on all over the world. Western Europe, Australia, Canada, here, Argentina, China, Japan, Korea. People are devoting themselves, outstanding modern molecular biologists, virologists, and physicists to keep on teaching us more of why this is happening, so that synthetic chemists can then create molecules to have impact on themselves. I'm going to stop there. I want to thank you. And I think if anybody has any questions, I'd be happy to answer. Yeah.
You get a relapse, you haven't changed medicines yet. How much damage is done in that one area? It's worse, or it's only the new things that's going to happen, or can it be, if you get the new medicine faster? Can you prevent any more damage than that one thing that was already damaged?
So let's take the scenario you just presented, which is a very good one. Person's had a relapse. Remember, what's the first thing you do? High dose steroids to shut down that. Now, from my way of thinking, what we're really trying to do is control the biological activity of the disease. And if a person has a relapse, the medicine you're using is not to adequately controlling the biological activity of the disease. So you have to seek a substitute. Now, the other aspect of it, however, is that relapses don't occur. There's a long duration in relapse. That's the time. That's the time to select right medicine. That works differently is one of the importance of medicines that work on many different mechanisms. So if a certain medicine fails, well, then all the drugs that use that mechanism shouldn't be failed. They should be something with a different mechanism. However, sometimes you have to wait to see if they wash out. Right? You can't have one on top of the other. So some of these medications are long lasting. Or in the case of Lobagio, you actually have to remove the drug, because if you don't, it could stay in you up to 2 years. That's why it's during the cholesterol, and that's how you get rid of it. So there are a number of things that mediate what medicine you select as the next medicine and how long will it take. But you're absolutely right, you don't know it's so long that people are spinning relapses. So one of the tragic stories that occurred back in the 1990s, no, sorry, it was 2010 or so, out of fear for a disease called PML, and people on disability are at risk for that disease, it's the virus called JC virus. And there was really goes up after 2 years. I'll mention where it was, but a very famous Stanley Center, they decided to take all their patients off stopping for drug holiday to reduce the risk. And 30% of them got massive relapses within 3 to 6 months. You can't wait forever. That's a perfect example. So friends, what we do, if we want to take a patient off the salvage for some reason, we start a new drug 4 weeks from the time they have the last space, because we know they're not going to wait around. Do the wash out of the cell. And it varies from drug to drug. If it's from Golan, it has a longer time course. Sometimes the white blood cell counts are very low, and you don't want to make the person have to risk of an infection. So another things that go into it. Right now, the other part of your question is, I think if I understood it correctly, was what else is going on? Is there more stuff going on? It would be naive in the extreme to think that only the lesion you can see on an history, or only the abnormality exam you can elicit, is the only place it's going on. It's more likely than not that there are small ions that you can't see on an MRI scan or detect on exam. But again, they should be just as susceptible to those high doses of steroids to shut down and to protect. You want to protect, preserve your nervous system. So you have to have a way of stopping relapses, and you have to have a way of preventing relapses. That we can do. But the challenge, as I pointed out to you, is what do we do about the progressive disease? I'm very optimistic that we're beginning to understand that level, that we're going to be able to develop a whole new generation of medications that probably will be used from the very beginning along with the relapse medication. Because probably this microglial activation probably starts with the first attack. And it's only over time that it becomes big enough for us to see. Yeah.
Following up what her question and what you said too, is that if you have a relapse or activity and you're on, let's say, one of the highest efficacy medications, and at that point, is your only option to go to a lower end?
No, fortunately, we have basically 4 separate categories. So, for instance, let's say that a patient needed a high efficacy medication, and there's a variety of reasons for needing it. And you say, well, I think I'm going to use medicine. And you discover these people already have a very high level in their body of the virus that causes PML, and it's off the that risk. So then you might go to an anti-CD20 patient. And it turns out that the person, and by the way, it's not likely that they have a breakthrough relapse, but that the anti-sphingosine phosphate receptor drugs involve and so on. So you can switch to other high efficacy. For me, I would never go to the lower efficacy. It just makes sense.
Another question based on what you said was, I've heard a lot of kind of argument back and forth about whether steroids actually make a difference in the course or progression of disease. Some people say like you can shut it down immediately, and some people say like it doesn't really make any difference.
So that's actually some of for that. In the early days, people used chronic steroids. It's a little bit, but ultimately it's unacceptable side effects. But in the acute setting, very high doses, the way you get very high brain levels by giving it intravenously, you can shut down the relapse. Right. Now, the idea that steroids don't work actually comes from an optic nerve trial called the ONTT. It's called the optic nerve neuritis treatment trial. And what they did was, they had patients with acute optic neuritis, where they either gave intravenous steroids with a taper, just oral steroids, or no treatment at all. What they found was that the intravenous therapy with no tapering afterwards had the best outcome in terms of preserving vision. They followed these patients for some 15 to 20 years, and yes, at 15 to 20 years, there was no difference between the groups. Why? Because most of them had MS and they were treating. But then, if you can preserve and give a nerve a chance of surviving, and we can still walk, because remember, this is a chronic disease. So every time you can save a nerve cell from dying, you're contributing to preserving the future. Chronic therapy does no evidence that steroids work at all. It can be harmful. But acute focused therapy is the good.
So I'm a late stager. I didn't get it until 55. And so I was in the nursery industry for 30 years and literally drank the water and found out at 3 of the wholesale nurseries that I worked at had groundwater contamination due to pesticides and herbicides. Has there been any research done? on
So
that?
in a generic way, and I'll get more specific in a second. In a generic way, aluminum, pesticide, none of that's really kind of that.
Okay.
However, there's a guy who's a terrific neurologist at Cornell University who learned through reading some Scientific American or something that ungulates, animals that eat grass, get a disease that looks like MS. So he started studying goats and llamas and, House of Queens looks like a menagerie. And what he discovered was that bacteria that grow on the grass
Okay.
produce a toxin that is eaten by grass-eating animals that causes the disease. They actually took the chemical and administered it to animals, and under the microscope, it sure looks like MS. Now, they don't develop relapsing disease, but they get it's neurotoxic. Okay. There are other neurotoxic chemicals. There's something called clopazone, which is a copper derivative that's used in research to cause demyelination in the absence of inflammation. And you can get exposed to clopazone by accident. So there clearly are chemicals that can damage the nervous system, even lead to demyelination, death of nerve cells, but they're not inflammatory. Think about MS. MS is an ongoing attack. And that's not the same with chemical exposure. I wish there were chemical exposures, instead we could just go around. But really that data is not held up.
Maybe stand for 1 or 2 more since I know you have a commitment.
Yeah, guys, somebody's gonna feed me. I guess. Yeah,
So, thanks to that mess, I was told I got 7 lesions. And I was given plasmapheresis, which seemed like it completely reduced all of the symptoms. But then I got a stomach infection and I got 2 more lesions. And that's when they pushed me to Ocrevus, but they told me that it wasn't going to fix any of the symptoms that I was now experiencing. It was just gonna stop me from getting new ones. But what Ocrevus has done is completely halted majority of those symptoms and reduced them to actually a normal life. So why is it that like sometimes it does reduce the symptoms and sometimes it doesn't? I've asked this many times to many doctors and none can give me a straight
well, I
answer.
think the answer to that is, first of all, it depends on where in the life cycle of the relapse you start the opioids. Now, if you start it while it's still active, you're destroying the very cells that drive it. Why shouldn't you get some recovery? Why? If, however, you've got a deficit that's been there for a while, it was no longer any active inflammation, just the scar that damaged the cells, no, it's not going to get rid of that one, but it should prevent new ones. So it varies with the timing and the cycle of inflammation as to where you introduce the drug. I don't know how many, I'm not asking for show of hands, but I don't know how many people have gotten plasmapheresis. Plasmapheresis to me is a desperation move. Some people, the first time especially, they feel transiently better. And I think the reason they feel better, remember I talked about these chemicals called cytokines, these pro-inflammatory proteins. They're in the blood, plasmapheresis removes. So you lose that pro-inflammatory drive temporarily. But the benefit generally doesn't last any more than 8 weeks. And that's why it's not big in the long term. Practical. Yeah,
So you're saying before that if there's interactivity, even if you don't have any symptoms, if there's activity, you want to hit it with high dose steroids to,
well, it depends on the kind of activity you see. So if the activity is an enhancing, calorie enhancing lesion, we know that's less than 6 weeks old. Let's hit it. We know there's active inflammation going on. Person has 3 new lesions that occurred sometime between the 1 year since the last MRI scan, but we don't know when. That's not stable.
oh my,
So you don't know when it's occurred.
right. So my question then is, if we're doing MRIs every year, are we missing, this activity that might be happening between that we don't know about, we can't hit it, we don't know about it?
So the reason we do MRI scans once a year should come as no surprise to anybody. It's insurance company. Yeah. Secondly, how long do you have, any of you have to wait to get your MRI scheduled? With the seasons, forever, right?
3 months.
Yeah,
3 months, 6 months.
it's terrible. It's tough. I think Providence probably has about 15 or 16 MRI machines just here in the Portland area. And the waits are just murder. We actually opened up a new place called Reed's Crossing to take some of the pressure off of the others on the west side of the river. It's that difficult. So you're much less likely that any event going on between MRI scans if you're in a high fixing bed. If you're on an Ocrevus or a considerable,
So you won't need the extra pregnant, the
if you don't have a
steroids.
relapse and you don't have any innocent lesions, in my mind, no justification for steroids. Steroids are a short-term answer to shut down an acute relapsing.
Thank you. Right, David? I have, so that's one.
Well, that is true. That's exactly what I'm talking about. There was someone else here. Yes, ma'am.
I've been on Avonex for 20 years, since I was diagnosed, and I haven't had a relapse since.
Yeah.
My lesions have changed, but my doctors say I can stop medication at 65, and I'm 58. And that's a little scary for me. Why is that really true?
Because I made this a bias against them.
Yeah.
I assure you, I'm the oldest person, so I know from whence I speak. There is actually no data that supports stopping at a certain age. There's a concept called immunosenescence, that the immune system becomes less effective as we get older. It's true. That's why older people are more susceptible to pneumonias and sepsis, things like that. So the assumption is, well, if there's immunosenescence, that means that there's also autoimmune senescence. Never been proven. Okay, and a number of people have done some discontinuation studies. There's a study that was done at the University of Colorado by a guy named John Corbin. He's head during this program. And I find the program was unconscionable. They just got explosion of disease. So I would say that there are several reasons for stopping therapy. The person is so disabled, unfortunately, from the disease, that the likelihood they will gain benefit is far outweighed by the risk of the high efficacy. You just know they're not going to benefit. That's one reason. A second reason is that they have other such serious diseases that coexist that it makes it too dangerous. It's not your age that counts, it's how healthy you are that counts. And what we've seen is people maintain careers, being able themselves to raise their families. Why shouldn't the person who's 70 have the quality of life of other 70-year-olds? Why take the chance? Whoops, I made a mistake. I mean, come on, you're not a white rat. I'm 59 year old, 58, no,
58.
58. Yes, ma'am.
Is the interferon category considered low efficacy?
It's that along with Copaxone will go up to.
What about Rebif?
Well, that's a beta interferon. So there's 3 beta interferons. There's Avonex, which is the interferon beta 1A. There's Rebif, which is interferon beta 1A. And then there's beta seron, which is 1B, which is slightly different. Those are what we call the platform drugs. All right.
The initial ones.
And now again, they used as the comparators to the new drugs. So look, there's an example of someone who's been on for decades and Shenfield. I was one of the original investors. I'm so excited when that works. We have 4 centers. I thought we ran out of money, so we had to look at the data. And it worked. I wanted to call it beta miracle, you said that to you.
I
So,
just wondered if that was still, I've been on Rebid for 20 years.
yeah, same story.
So that's why I was curious if
There's-
that's considered too low efficacy.
No, not if you're stable. What I would say to you is you're not a population, you're an individual. And it's individual variability. And if you're on a medication, unfortunately, not fortunately, but you got the disease, but fortunately, the level of the disease is so low that a more modest medication is all you need, and therefore you're not taking the risk of the higher medications.
Okay.
Of course, you should stay on.
Yeah, I'm just curious about neuroplasticity studies because I've seen maybe some mouse studies that say it's possible, like certain psychedelics might be able to remyelinate, and it's sort of out there. Do you have is
So
that come up in your
neuroplasticity-
discussions?
So for those who don't know, neuroplasticity is a term that's used to describe the ability of nerves to adapt. Now, neuroplasticity is a universal phenomenon which gets ever less as we get older. So for instance, there are children who have brain injury who have intractable epilepsy, and you can remove half of their brain and they grow up like a normal. Not for a 75-year-old. Right? So neuroplasticity in part is determined by age and level of maturation, but also the presence or absence of disease. Now, if, for instance, we do develop medications that can regulate the genes that promote nerve growth, that would be an example of the restoration of neuroplasticity. Currently, we have no drugs in MS that do that, despite people's claims. The evidence that some medications may produce remyelination is all based on very indirect MRI scan. They're not actually seeing myelin. So maybe they're right, but there's no actual evidence that they are current medication. Now, again, if you control disease inflammatory activity, maybe you give a chance for the surviving cells to remyelinate. We know remyelination occurs because we know that's more toxic material. We can tell whether it's remyelinated versus the open myelin. Okay, so we know what happens. But unfortunately, in most cases, it doesn't occur at a level significant enough to make a difference. Yeah.
For the machine learning MRI scans, how is that used in clinical practice?
Well, we use it in ours. There are a number of different companies that make this software. And it's all FDA approved. The FDA is convinced that it is, clinically reliable and so on. So we started using it about 3 years ago, really as a research project. No one has really been able to compare all the medicines. We have 4,000 patients on all the medicines. So imagine if we could do MRI scans every single year. We could compare the efficacy of the different medicines on changes in the brain. And no one's ever been able to do that. So that's what got us started. And yet, as I spent a lot more time on the scans now than I even used to, because I did all this extra stuff. And there's no question, it picks up things that you can't see. So I think and it's not expensive, it's inexpensive to do. It costs about $35 a scan to do this. And it's just a matter of getting the word out. And also, whenever something new comes along that you're already an expert in, you might feel threatened. So here, radiology is being pummeled by artificial intelligence. And they're going to be very vulnerable. He's no wise ass neurologist who shows up. It's the thing he wants them to use, and here we go again. But they're beginning to realize also that it's not a competition that actually expands their ability to give more detail and more insight. Yes, sir.
Does the power of the MRI machine make a difference on this AI?
No, as long as it's over the 1.5 Tesla machine. Now you speak to the company that we use, and everybody got the 3 Tesla. Well, everybody isn't 3 Tesla. It's not like our 1.5 Tesla machines are so good that they actually give better images than the 3 Tesla machines. What you do need, however, when you're doing this, it's got to be on the same machine every time. You can go to 2 different machines, the same manufacturer, the same model number, the same software, and the speeds can't be compared. So that's why we strive to always use the same machine. And we're collecting the evidence. We're learning a lot.
Try to say it again.
Boy, imagine.
Oh, okay, sorry.
I wasn't staring.
Yeah. So I'm wondering why Ocrevus is also used in people with primary progressive.
Because it was approved by the FDA. So they did a study called Oratoria, in which they compared Ocrevus to placebo in people with primary progressive disease. And they got a signal, therapeutic signal, about a 24% reduction. I think that's the problem was with that study for the results is that virtually all the patients who benefited had relatively recent onset disease or had activity on the MRI scan. And I think really what they were treating is people who still had some inflammatory relapsing, inflammatory activity, but they just never had clinically observed relapses. Therefore, they were primary progressive. We need stuff much better. So Palomar makes it approved for secondary progressive. The only patients who benefited were secondary progressive patients who also were having relapse. So we have to realize that we have to be approaching people thinking that's not a comfort. And the longer you're progressive, the less and less likely to have the kind of inflammatory activity that drugs like look any medications that get into the brain. The antibodies don't. Yeah, last question. Waiting in the.
Yeah, so going back to this question, how often do you use AI to look at the changes, the progression of changes? How often do you use the AI to find the progressive changes? And because you're saying that it's as sensitive of having to use the same machine every time to be able to detect those changes because you will see different, like, what's the case?
No, if you don't use the same machine each time, the differences you see may not be entirely right. You see the difference because it's real. All right, first the radiologist reads it, then it goes for the machine analysis,
Yeah.
then it comes back to the neuroradiologist. They then review that and then alter their report based on what they saw and it was revealed by the
Yeah.
And that's how it works.
I'm just concerned because the time frame to schedule the MRI, you're not gonna get the same machine, like.
Well, it depends on where you go. So many of us centers only have one machine. It's only the big places, us and Portland have one machines.
Yeah.
And Providence, to its credit, despite the enormous financial crunches in COVID, has invested in new machines and all the machines are just absolutely top for it.